Hi, and today we'll speak about a syndrome called as PRESS syndrome, which is progressive reversible encephalopathy syndrome. And I've added the extra S is because there might just be loss of consciousness, and the patient goes into a state of drowsiness, altered mental status, and stuff like that. So that's how I remember what is PRESS. Now, the idea is to understand PRESS, you might just have to watch the video on preeclampsia. But I've tried my best to explain it in a few slides or in a few minutes. So, preeclampsia is when the blood pressure in a pregnant woman is 140 by 90 or higher, and that is calculated on two occasions by a sphygmomanometer that have a duration of 4 hours between them. So that is important. An isolated 140 by 90 does not definitely warrant. Also, there are other things that I haven't written but should be of notice is that there would be edema and there'd be proteinuria. Note, for preeclampsia, the patient's BP should be elevated after a period of gestation of 20 weeks. Before that, we say that the patient has gestational hypertension or probably even chronic hypertension. Now, again, if it is from the start, that is from before or at the beginning of conception or whenever detected in the first antenatal visit, you could say that the patient is in a chronic hypertension and not just preeclampsia. So yes, the 20-week is kind of an important thing that should come in people's mind when they talk, especially about preeclampsia, after 20 weeks, right? And other criteria should be that there should be proteinuria, all right? Otherwise, it would just be gestational hypertension. And proteinuria would be around 0.3 gram per DL, all right? Protein by creat, or a persistent proteinuria of greater than 1 and dipstick, again tested 4 hours apart, or a mean arterial pressure of more than 105, again tested 4 hours apart on 2 occasions. Correct. Now, the idea that I'm trying to get into is that a pregnant woman, right, with preeclampsia would have low soluble FMTs. That is something that I have circled, right? Soluble FMTs are these protein molecules that bind to VEGF and platelet-derived growth factors and vascular endothelial growth factors. And they prevent revascularization, they prevent neovascularization. So in that process, the blood vessels of the uterus and subsequently of the placenta are yet high resistant vessels, and there is less vascular remodeling. Vascular remodeling is majorly taken up by the chorionic and cytotrophoblast, right? That kind of go and definitely remodel the entire vascularity. Even that doesn't occur, obviously the blood pressure in the uterine vessels and of the placenta is going to be much higher. When it's much higher, we need to understand that endothelial damage would definitely occur. Now, because the endothelial damage is occurring, the patient is subsequently getting into a preeclampsia, all right? This modeling occurs in 2 phases, this vascular remodeling. It occurs in the first trimester as well and also in the second trimester. So when the second trimester part fails, we are more or less concerned with preeclampsia. That is something that goes to the core of this entire part that we are speaking about, PRESS. Now, when preeclampsia has occurred or it's getting worse and it's going into eclampsia, that is, the patient is throwing seizures and having end organ damage. The patient might also have something called as a PRES, which is a progressive reversible encephalopathy syndrome. Now, what is it especially that I'm speaking about, and why am I speaking so much about preeclampsia and eclampsia, is that it is so difficult, or probably even not even important, to actually differentiate preeclampsia from from PRES from eclampsia, is because eclampsia has almost the same features that PRES syndrome has. So when we are speaking about eclampsia, probably in the next video, you would see that the clinical features are almost the same as eclampsia. And to name a few clinical features, first is you're going to see hypertension, because without that, the entire clinical sequelae wouldn't even proceed in the first place, right? So we've got hypertension here, and then we're looking at a reversible loss of consciousness. All right. Very important is that there is seizures, which is going to take you to eclampsia always. That, you know what, even eclampsia has seizures, so there's a very high chance. There is going to be vision loss, and there's going to be headaches. Now, the idea is that when there is so much of hypertension and there's a preeclampsia and there's a preeclamptic episode, the vessels to the brain might just undergo hemorrhage and infarction, which is causing all of these clinical sequelae. On T2 MRI, you would definitely see edema, again because of hemorrhagic or infarctive episodes, mostly hemorrhagic because hypertension, obviously. Note, PRES can be associated with eclampsia as well. So I know it's a small unit, PRES, and definitely we will also get into HELP in another video. But PRES is important, might just be tested on test day when eclampsia is not given and PRES is given. So that is about it. Thank you.